My name is Radley Fischler, and I will be going over the respiratory system. So, initially, we have physiological changes in the elderly, and that includes the skeletal system beginning to change, causing your chest cavity to make adjustments. So, we have calcification of cartilage, which really happens, especially if you have osteoporosis, which women are more predisposed to. And then you have the outward curvature of the spine, which becomes more exaggerated, and the lumbar curve becoming flat. And you can see in the photo how we have kind of the hunchback picture. And these changes affect chest expansion, and they may give the older person a barrel-shaped chest. So that also can cause them to have to use their accessory muscles to breathe just normally and get a normal amount of oxygen in. So then we have further physiological changes. According to Lewis 2016, within the lung, the number of functional alveoli decrease and they become less elastic. Small airways in the lung bases close earlier in expiration, and ventilation is less well matched to perfusion, ultimately lowering your O2. So that's not good. Respiratory muscle strength declines after 50 years of age. And so this can contribute to why older adults have reduced activity tolerance, especially past what they normally do for exercise. So this is kind of talking about how important it is to continue exercising in like equal amounts as we go on through our lives. That way we can continue to keep our exercise tolerance up, and that can help our muscles stay strong so we're able to keep breathing normally and continuing to do the things that we would normally do, just like normal daily activities, as well as exercise, because that is important. Just like it says, it is important to exercise daily to be able to sustain activity throughout your life. And then we have our last physiological change slide is about our respiratory defense mechanisms and how they begin to decline as you age. So your alveolar macrophages become less successful at phagocytosis, and your cell-mediated and humoral immunity starts to decline. And something I found interesting is actually that the formation of secretory immunoglobulin A, which is super important in defense, starts to become significantly diminished. So obviously that's going to affect the way your body is able to fight off infection. And Lewis also talks about an older patient has less forceful cough and fewer and less functional cilia. Mucous membranes tend to be drier, and retained mucus predisposes the older adult to respiratory tract infections. So again, that's sort of self-explanatory. If your cilia aren't working as well as they used to be or aren't working well at all in general, it's going to be really hard to get those bacteria and viruses that are caught in that mucus up and out of your body. Instead, it's going to go in, it's going to sit in your bronchioles and your lungs, and it's going to cause infection and inflammation and all of those other things that can contribute to, being sick. I also thought it was interesting that swallowing becomes slower because of transit time in the pharyngeal area, and there's reduced sensation in the pharynx, especially if the older adult has a neurological condition, like they've had a stroke or something like that, and that can really contribute to aspiration. So that's like choking and breathing liquid or things like that into your lungs. And if you have those kinds of things, like we talked about earlier, if you're having like foreign objects and foreign fluids in your lungs and inside of your respiratory system, and your cilia aren't working as well, so they're unable to get that out, then those are going to sit in there, and they're again going to cause like bacteria, inflammation, kinds of infection. Next, we have complications. So I sort of just added this to sort of think out of the box. It says older adults are more prone to invasive procedures like hip replacements, heart surgery, stent placement, etc. After these procedures, it is important to encourage deep breathing and exercise. So I think we all have read and learned that we really want to get people up and moving after they have surgeries, because when they just sit there in bed and they don't move around and they don't do those deep breathing, maybe because it's uncomfortable or they've had surgery and they're sort of afraid, that causes all of those mucus and just like fluid buildup in the lungs to sit there, and that's not good because it can cause pulmonary edema. It can contribute to poor circulation if you're not up and moving around, and it can really cause pneumonia. That's a big cause of pneumonia. And we'll talk about this a little bit later, but pneumonia is a big respiratory issue in elderly adults. And we will see why in just a second. So when we talk about assessment, I personally think it's really important to go over things like medications, health history, daily living, respiratory illnesses specifically because we're talking about respiratory, allergies, cardiac health problems. So medications I really think are important because these are the things that they're doing every day. There's a reason that they've been prescribed these medications, and it's super important for us as healthcare providers to understand why they're taking them. Make sure they understand why they're taking them, and how they can interact with other medications they're taking, or if they could be a cause of what's going on with them respiratory wise. Just sort of know those things so we can be prepared and kind of work around that. Health history is obviously important. Prior surgeries, diagnoses, immunizations. So when I talk about immunizations, I think it's fairly, applicable to ask about pneumonia if they've had the pneumonia shot, or if they've had pneumonia in their life. And I'm pretty sure that's for 65 and older. But I do think that's like an important thing to ask when we're dealing with respiratory and elderly adults. Prior surgeries is a good thing to talk about just so we can kind of know what we're working with. And diagnoses, well, we all know how comorbidities work together and how they can kind of contribute to each other. And hurting a little bit, I would say, whenever you're working with two different diagnoses, it can kind of cause conflict. And then I think it's important to talk about their daily living, what they eat, what they drink. Do they drink enough? Are they hydrated enough? Do they get out and exercise? Do they have problems walking across the room? Do they have trouble sleeping in a chair? Or do they have trouble breathing at night so they have to sleep upright in a chair? Can you make it a block without stopping? Are you having trouble breathing? Are you having chest pain at home? Things like that are just sort of more intimate questions, I would say, and things they may not think about telling you if you don't sort of ask those questions. Respiratory illnesses, I think it's important to ask about that because that's what we're looking at. COPD, asthma, sinusitis, just sort of like allergies. And tuberculosis, obviously, would be a good question. And that also goes with immunizations. Allergies is a good thing to ask about. Pollen, dander, drugs, oils, foods, any kind of reaction that could cause a respiratory flare-up. And then, this is kind of out of the box, but cardiac health problems, because we know how cardiopulmonary circulation really goes hand in hand. So I think it's important to have that information on the chart and in our minds, just so we can think about, okay, this could be correlated, etc., etc. And then when we come to objective assessment, I think that something to be mindful of is the previous diagnosis, as we talked about. So if they have COPD, something that would be fairly normal would be pursed lip breathing or tripod position. Those things would be to be expected. And also just a reminder, with COPD, you need to watch oxygen, how much oxygen you're giving. And then again with that, like if they have pneumonia, or if you're finding dullness or fine crackles, that could be pneumonia. Things like that, just so we know sort of what we're looking for. And then according to Chester and Rudolph, increased release of proteinases causes degradation of collagen and remodeling of vasculature, which can appear in normal aging to resemble a constant state of inflammation. So again, when we have that inflammation, you might hear wheezing, you could hear sort of like hyperresonance if the lungs are actually hyperinflated. And then older adults may have an increased respiratory rate to compensate for the decrease in tidal volume. While this may not affect day-to-day activities, it does reduce physiological reserve. For example, patients may be able to walk on a level surface, but inclines or stairs increase the oxygen needs and the body is unable to compensate. So we sort of talked about that earlier in the first slide, just how if you're working out or exercising regularly, you're going to have a limitation to what you can do. And I think that's pretty much equal for everyone. If I'm asked to exercise too much in my current state of health, it's going to be difficult for me. But I think we should especially be mindful of what we're asking the elderly person to do, just so we know their limitations and so they know their limitations and they feel comfortable with what we're asking them to do and they don't get out of breath or lightheaded, dizzy, any of those things. We wouldn't want that to happen. So with COPD, chronic obstructive pulmonary disease, COPD, it's a preventable and treatable disease characterized by persistent airflow limitations that is usually progressive. It is also associated with enhanced chronic inflammatory response in the airways and lungs, primarily caused by cigarette smoking and other noxious particles and gases. So obviously, if you're breathing in smoke and chemicals and all of those things, that's going to irritate your lungs. That's going to cause your alveoli to hyperinflate. Then it's going to fill up with mucus, like it was saying. In here it says mucus hypersecretion and bronchospasm, which causes airflow limitation. Obviously, yes, if you have something in the way of your bronchioles, it's going to be hard to move that air in and out, especially if it's hypersecretion, because that's extra mucus and that's building up in those alveolar ducts, making it hard for oxygen to trade with carbon dioxide and go into the bloodstream. So that's bad, obviously. And then we also have pneumonia here. And pneumonia is that's just a big one for me because I read earlier, I can't cite my exact source, that that is a number one illness that elderly adults are plagued with right now. And so I think it's super important, like we talked about earlier, talk about the vaccination, that's for 65 and older. Talk about if they've had pneumonia before, things that can cause pneumonia. So like super important to wash your hands. If you're in the hospital, you need to be doing that spirometry. You need to do that. You need to get up. You need to get moving. You need to cough. You need to take deep breaths. Things like that can be sort of preventative care. That's very important. So Tupko, Morton, Annunzo, and Retrespo say changes in basic lung physiology as a result of aging include decreased elastic recoil, increased air trapping, decreased chest wall compliance, and reduced respiratory muscle strength. And these factors may act to increase baseline work of breathing, giving older adults less reserve to cope with bacterial infections in the lung. So that's sort of, I would say that has to do a lot with preventative care because we know these things. We know that these are all factors and they kind of predispose the elderly population to pneumonia. So we need to be hyper aware of what we're doing with them, how we're teaching them, make sure they understand what we're teaching them, and they're doing it pretty much. So again, we can talk about like just doing the spirometry. That's important, especially after surgeries or in the hospital. Get up, get moving, do those deep breathing exercises, things like that it can be really helpful because if that mucus, and also this goes back to talk about the cilia that aren't really working as well as they should be and have decreased function. If you're not able to cough as well and you're not able to get those things up and out of there, that mucus up and out of there with those bacteria and viruses, then it's going to go into your lungs and your bronchioles. It's going to sit in there and it's going to create a perfect environment for infection. So that can be avoided. The next slide we have is, again, just about common illnesses that old people encounter. And this is mostly about asthma, and Lewis talks about how asthma is characterized by a combination of clinical manifestations along with reversible expiratory airflow limitation or bronchial hyperresponsiveness. Signs and symptoms can include episodes of wheezing, breathlessness, chest tightness, and cough, particularly at night or early in the morning. So again, if you're unable to get that air out, then it leaves less room for you to get air back in, and that causes decreased oxygenation. Triggers include pollen, dander, and other allergens, as well as sinusitis and drug allergies or food. So that's why it's super important, like we initially talked about, to ask them these things like, do you have allergies? What are you allergic to? Have you been outside recently? Things like, because these allergens can be triggers and they can cause a respiratory inflammation and an act up of any respiratory symptom that can cause an asthma exacerbation and just lead to further complications. The primary physiologic process in asthma is persistent but variable inflammation of the airways. So that's edema in the airways. And I think just like with edema anywhere else, it makes it hard for blood to flow, air to flow, things like that. It's an obstruction. Airflow is limited because of the inflammation results in bronchoconstriction, airway hyperresponsiveness, and edema of the airways. Exactly. And mucus production also. I'm not sure it's as much as in COPD, but I do know that mucus production is something that can also block up those airways with asthma. And if you think about it, if you're having an allergic reaction to something like pollen, those goblet cells are going to make that mucus because they want to kind of get that stuff all stuck to the mucus and get it out of your body. And that way you're not having that reaction to it. That's what you're doing. And your histamines are coming out and you're getting edematous. Anyways. So things that we can do to kind of help this situation, help it be better, is educate our patients. I think something that's important to educate about is medication costs. A lot of times a provider will write a prescription for a medication, but it could be expensive. It could be super expensive. And if you're living on a fixed income, if you have any kind of financial obligation, other financial obligation, and you're unable to afford that medication and you don't take that, but you need it, there can be very serious consequences to that. So I think it's perfectly acceptable to encourage the patient to talk to the provider about that, talk to the insurance company, and if you have the opportunity and you have something to do, like you have a role to play in that, you absolutely should. You should always advocate for your patient in that way, especially if you can, because it's important and you would want someone to advocate for you if you needed help. Medication adherence, again, is something I think that's very important. Again, the medications have been prescribed because you need them to make sure that you're taking the medications. You can instruct the patient to keep a medication diary, so you can write, Monday, took medication in morning, check. Took this medication in morning, check. And that way you can check them off so they know that it's been completed and they've done well on that. You can also write if there's any kind of reaction to that medication, or if you took it on an empty stomach, or if you took it with this food, or just any kind of change that you experienced by taking that medication. You can keep that in your diary, and that's super helpful. A medication organizer is a really great tool that can be used. You can get them at Walmart, Target, anything like that, and you do have to put your medications for the week in each little slot, but you can put it like morning meds, afternoon meds, nighttime meds, and it has Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. So that way you know what you've taken and what you haven't taken, and it's an organizer. It's very handy. You can also have someone keep you accountable, like a spouse or a friend or a family member. They can call you in the morning, say, have you taken this, mom, or have you taken this, dad, or have you taken this, friend, anything like that. So that way you have someone looking out for you and you know that they're going to be calling you to make sure that you've taken the medication. I think that's helpful. Also, if you have any questions, it's always important, and you should always be able to call your doctor or a pharmacist and ask them that question. If you're unsure, if you feel strange about taking medication, if you forgot what it's for, there's never any shame in just reaching out and asking, because it's better to be educated and know what you're doing than to do something wrong, I would say. And lastly, it's super important to keep a list of medications that you take with you. That way, when you go to various doctor's appointments, you can say, this is everything I take. And they'll know, and they can cross-reference those medications, see if there's any interactions. If you're having a rash, per se, I know it's not related to respiratory, but if you're having a rash, it can be because you have a medication interaction. It's just a super helpful, safe way of keeping track of all the things that you need. So it's smart. Another education slide, I know this may seem super just self-explanatory, but it's really important to wash your hands. This is the main way the germs are spread, especially if you have any comorbidities. It is important to stay clean and dry. So if you're a diabetic, you have decreased immune function. If you're an elderly person and you're having decreased immune function, there are just so many different ways that your body can be attacked if you're not washing your hands. You could touch your eyes, you put food in your mouth, you blow your nose, and then you spread all of those germs to everyone else, and it's gross. It's just gross. So wash your hands, 20 seconds, friction, hot water, soap, important. Hand sanitizer is good too, but I prefer to wash my hands. It just covers all your bases. When you're sick with a respiratory illness, try your best to eat healthy, nutritious foods and stay hydrated. The hydration thing, I know that's kind of confusing. I did some research on it to make sure I was right too. But so we talked about in COPD, for example, how I know that's not an illness that's necessarily curable, but it is still important to take care of your body and hydrate, because if you're making all that mucus, that's pulling water and fluid from your body to make that. So you're going to get dehydrated. And if you're blowing your nose a bunch, things like that, you're going to need to hydrate. And your body needs healthy foods and good energy to fight off those germs. So protein, that's always good. I like protein, chicken, fish, red meat if you have to, vegetables, fruits, mangoes, peaches, spinach, broccoli, cauliflower. I could go on and on. When to seek medical attention. So, if you're having respiratory flare up or illness or respiratory anything and you're getting worried, that's probably a good time to seek medical attention. If you're genuinely worried and you're not feeling good, there you go. That's a good reason right there. But extreme shortness of breath, dizziness, lightheadedness, trouble walking through the room, trouble breathing while sleeping. So, like if you're having to use a bunch of pillows to sit up and breathe, or if you're having to sit in your recliner to sleep, that's an issue. You need to go to the doctor. Chest pain is always, for me, I'm like, okay, that's not good. You need to go see someone. For asthmatics, I know I have asthma, so the feeling of kind of like someone sitting on your chest in such restriction, that is not a good sign. If you have a nebulizer, you should use it. If you have an inhaler, you should use it. If you don't, you should go to the doctor. Also, those peak flow meters are a good way of knowing kind of where you're at with your breathing. That helps me. You take a deep breath in, you blow as hard as you can, you look at the line, see if you're in the green zone, yellow zone, red zone. Red zone is doctor for sure. Decrease urination. So that kind of goes back to the dehydration portion, which is not good. You never want to be dehydrated. So that's the time you can call your doctor. Wheezing, that means that you're having trouble getting air in and out. That's a red flag. Excessive coughing, that can cause a lot of different things, to be honest. That can cause a lot of issues. But if you're coughing a lot, that probably means you're having an obstruction and it's not good. Skin turning dusky or pale. If you have an O2 monitor, you should use it so you can see where you're at. Because if you're turning dusky or pale, that is not good. Okay, that is the end of my presentation. Thank you so much.